All right, welcome everyone back to another virtual shadowing session at Hearts for Health. Today, I'm pleased to tell you that we're joined by Dr. Rohr. She's a past president of the American Medical Women's Association, or AMWA, and also the vice chair of AMWA's physician section. She'll today be going through quite a few cases in adolescent medicine. Between the cases, she'll have some questions for y'all, so definitely be sure to type in your answers in the chat. And just to get us started too, definitely type where you're coming from, what state, Texas, California, New York. We know that we have quite a few people across the state, so it's great to know where you're at. I do have a few reminders though for y'all before we get started with our cases for today's presentation, especially if you're new. So I might have already touched on this already, but we do have a Q&A, and that Q&A will be saved towards the end of the session as we wait for answers, I should say, through the chat for Dr. Rohr's questions. We will have a mini Q&A with just a couple questions. So if there's any questions that you have for Dr. Rohr, please do type them in the chat as we go through this presentation at any point in time. The second reminder I do have for y'all is in terms of how to stay in tune with us for future shadowing sessions. So you might have heard about us through an advisor, through a professor, through another student, but we do have two ways that you can stay in tune with us. And that's through our Instagram page, where I'm sure many of y'all have seen our flyer, or through our listserv, where we also post our flyers on a weekly basis, though, instead of more often on our Instagram page. And that will include the same content, both our flyers. We do have some extra opportunities, though, particularly during this time of year. This fall, we're going to be launching our mentorship program and a couple other volunteering programs. We have non-clinical volunteering, and we do also have clinical volunteering. They all have their own details. Some are in person, some are virtual. If you'd like to look into more details, we do have our website where we list more information on each of our programs. But like I said, we do have a pretty good variety, clinical and non-clinical. So I definitely check it out if you're interested. And that's really all to say. If you do have any questions for us, please do feel free to email us. We're happy to answer any questions that y'all have. And our email is community@hearts4health.org. Our website is hearts4health.org. Again, if you have anything that you'd like to ask, whether it be for our virtual shadowing program or any other of our other programs, feel free. Other than that, I don't want to take up too much time. So Dr. Rohr, take it away.
Hey, thank you so much. But Michael, you'll have to tell us later how you got the y'alls. You know, that's supposed to be a Southern thing. I don't know about it being from Texas. So, but thank you for putting this together. I think especially during the pandemic, it was really useful when we weren't able to have you in the office with us. So it was nice to kind of get things going. Besides, I always learn so much from clinical cases, and those kind of stick in my head. I'm currently in Athens, Georgia. I'm an internist by training, with my boards also in adolescent medicine. So I thought I could bring up some interesting cases, not only because perhaps adolescent isn't something that you frequently see in the office, but also because it's probably a little bit closer to your age range. So you might have experienced some of these things yourselves. I would appreciate you putting information or questions or thoughts in the chat so that we could perhaps have a little bit more of a robust discussion. Appreciate that. So we're talking about from the mundane to the insane, some cases in clinical. So the first one I want to bring up is a young kid that came into the office, 16-year-old, who came in and said, I want a stress test. So one of the first things you do when you take a history is you try to get an idea of what the patient's thinking about, and also what about their past medical history, and some more characteristics about the discomfort that they're having. We use something called old cards, which you have probably heard about. It's when was the onset, how long has it been going on, what's the duration of the symptoms. So let's kind of think a little bit about this young man. So 16-year-olds, he says he's been having this intermittent chest pain for the last 4 months. So intermittent meaning comes and goes. Otherwise, he's been pretty healthy, no significant past medical history. So I want to get a little bit more understanding of what does he mean by discomfort? And of course, everybody's always worried when they have the chest pain that they're having a heart attack. So you have to take it seriously. So the description of this pain for him is, it can occur at rest, especially sometimes when he's kind of sitting, watching television, playing computer games or something, legs up. It can be a really sharp pain. It can kind of come on really quickly, like almost kind of grabs him a little bit. It doesn't go anywhere else. It doesn't radiate any place. And that's also incredibly important. If that chest pain is grabs you, it's really quick, it's in the middle of your chest and it's radiating to the back, that's something a little bit different. It only lasts a couple of minutes and it can occur for a few days in a row, and then it cannot occur for months, and then it kind of comes back. It definitely does not occur when he's doing any kind of exercise. He's a dancer. He's out on the dance team where he's lifting up women, his young colleagues, but it never happens when he's doing that. That's another really important historical feature. So keep your ears open. Like I said, no significant past medical history. Doesn't have a history of sickle cell disease. Doesn't have any family members with it. Never been in the hospital. Doesn't have asthma. So all of those things are good, important features. He is a sophomore in high school on the performance dance team, and confidentially. So anybody over the age 12 and older, we automatically do a history alone, so without anybody else in the room, so that you can confidentially ask about these other issues. He denies being sexually active, never been sexually active. He doesn't do drugs, doesn't smoke. He identifies as Black. He lives with his mom and his 2 siblings, no other pets at the house, no other major concerns. And so on review of systems, there was nothing else. There was no reflux. There was no pain with exertion, no shortness of breath when this happened. So you always create a little bit of a differential after your history, so that kind of takes you on to maybe some other things you want to do in the physical. So for this young guy, WDWN, anybody know what that means? Well-developed, well-nourished. NAD, no apparent distress. Okay, I'm not writing out the whole history for you, or the whole physical for you, and we certainly don't want you to do abbreviation and do your notes. However, it's a quick shorthand for us. His vital signs: he had a blood pressure of 116/72, pretty normal for somebody his age. His heart rate was 61. He didn't have a fever. On physical exam, his lungs are nice and clear. I don't hear any wheezes, growls, crackles. His chest wall was without any tenderness. And what I mean by that is you actually will take your hand and push on his chest right in the front. And I'll show you kind of where on the next example. And let me tell you what the compression test is as well. Both of those things are negative, but I'll show you the example in the next. His heart was completely normal, regular rate and rhythm, with the normalest 1S2, so he didn't have an irregular rhythm, didn't have any abnormal murmurs, rubs, clicks, or gallops on his exam. And his abdominal exam was benign. No enlarged liver or spleen, was relatively soft and non-tender, and with normal active bowel sounds. Extremities, no clubbing, sinus, or edema, especially important when you're talking about chest pain, because any kind of blueness of the fingers or the cyanosis, the clubbing of the fingertips, kind of large widened fingernails, that might make you be concerned about things like difficulties with breathing and lung problems. So none of those was shown, and no edema, which is swelling in the feet, which is the first sign for when somebody has any congestive heart failure or low thyroid or other issues. So every exam usually includes at least lung, heart, abdomen, and extremities, and sometimes a little bit more. So when I talked about the chest exam, I meant about one thing is when you push along this area here, so you physically take your fingers and kind of push into these areas, what I'm looking for there is something called costochondritis. It's an irritation where the ribs and the sternum come together. This area can be inflamed and irritated and can give you some pain that almost feels like a heart attack, but it's reproducible on physical exam. So when I did it with him, no problem. The other is a compression test. And what I mean by the compression test, I'm looking specifically for rib fractures. Perhaps he has thin bones and the rib fractured when he lifted somebody up and it only comes back in a certain position. What I do for that is place one hand on the front of the chest, one hand on the back of the chest, and then physically push the ribs together. You could imagine if there was a fracture along any one of these ribs, that kind of compression from the front to the back would really make you hurt. So it's a great test to look for whether or not there's any rib fractures. So for him, no problem. So because he was complaining about chest pain, a couple of other things were done before he came to see me. So at least I have these records. His chest x-ray was completely normal. And important to do, maybe not in every case, but sometimes you'll have things like a pneumothorax, especially in a young, otherwise healthy young person. They can actually have a bleb in their lungs that explodes kind of, and it pushes their lungs all to one side. Would be pretty unusual to happen every now and again. So, but so be it. His chest x-ray was completely normal. Didn't have any fluid in there to make us think of congestive heart failure, and did not have any pneumothorax, which is the air taking the space of the lungs. The heart size was completely normal. The mediastinal contours were normal, which means the heart looked like it was in the right place. It wasn't enlarged. It wasn't bottle shaped. And the vasculature of the lungs also looked great, which might be helpful if you're thinking about odd things like pulmonary embolism, but it would be not the best way to look for that condition. All right. Anybody have any thoughts so far? Or any tests that you might want to do next? All right. Okay, well, an EKG had been done. The EKG, I mean, a lot of times you'll do an EKG, specifically if you're thinking about somebody having chest pain currently, because if you're having chest pain in front of me, the EKG can be incredibly helpful to look for signs of ischemia or decreased blood flow to the heart muscle itself. The EKG can also be helpful in a young person if there is any complaints of an arrhythmia or irregular heartbeat, or if a young person was actively involved in sports and passed out while exercising. All of those things, a baseline EKG can be really useful. In this case, pretty stone cold normal. All right, so this is nice. We're getting a lot of history. We're getting some data. Not all the data was actually needed for this case, but that's all right. It gave us some pretty good idea. So as we're going on, any thoughts, any considerations? Well, what this is something called Texidor's twinge or precordial catch syndrome. And I bring this up because it's very common. It is a great reason for benign chest pain in young folks. Usually goes away after the age of 24. And we think that there is just some growth going on. And if you can imagine that picture of the ribs that I showed you, between each rib, there's a nerve, there's an artery, there's a vein, there's muscle. And as you're kind of sitting, and especially if you're kind of in a crouched position while you're slumped and watching television or reading a book or something like that, the muscles between the ribs get a little bit kind of smushed, and that kind of smushes the nerve a little bit. And when it catches, it kind of pulls you up. It was interesting that this was something that wasn't really described until 1955, when Texidor, a physician, noted this in just like 10 people, and he talked about it with his colleague Miller, and he's like, yeah, I had that too. And just with those 10 patients, they wrote it up. He got his name on it. And then in 1978, Sparrow and Bird described it even more so, added another 45 patients, and it became a very well-known condition. The hassle is that the differential for chest pain is so large, and you do have to at least think about all the different possibilities and consider them, and then say, what is it about this presentation? What is it about this history that makes me more convinced of this being precordial catch or Texidor's twinge? So I think about cardiac etiology. Could this be a heart attack? Pretty unusual in a 16-year-old. However, I have had a 19-year-old who had an anomaly in the coronary arteries, in which the coronary arteries did not go over the heart muscle, but instead within the heart muscle, so that as a heart muscle pumped and the kid exercised, he had ischemic changes because the heart muscle actually squeezed the blood vessels, not allowing the blood to get to the heart muscle, instead of normally the arteries are on top. So even a young person can have heart disease, so that's always a possibility. Pulmonary GI etiologies, certainly if somebody was having, for example, pulmonary embolism, that would also give you chest pain, but it just wouldn't give you with these specific characteristics. Can you think of all of how sickle cell might give you chest pain?
While we wait for responses to roll in, one person asked, so in order to prevent precordial catch syndrome, it's best to have good posture, meaning the only way to get it is by having bad posture in the developmental stages of adolescent teens. Is that correct?
So yes and no. It's going to go away by itself. If you notice you always that it happens whenever you slump, then having good posture is good, but there's no way to really prevent it. It's more of a explanation. And once the kids kind of understand where it's coming from, then yeah, if you're in this position and that's when it bothers you, then don't be in that position. But it's something that you're definitely going to grow out of, and it's going to be very intermittent. And if it hits the same characteristics, you can rest assured you don't have to refer folks to cardiology. Although it's probably the biggest reason why kids get it referred to cardiology at this age range. But oh, so did anybody come back with how sickle cell could cause any chest pain?
Not yet.
All right, well, let me tell you then. Sickle cell is a really interesting condition, and it's fabulous. They're actually have some specific cures that are going on, so I'm excited for the future. But sickle cell is a condition in which the hemoglobin is not normal, and because of that, it doesn't hold on to the oxygen as well. And because of that, the cells, instead of being nice and round, becomes sickle in shape. Because it becomes sickle in shape, they clog up things and they get stuck together. So you could have some chest pain because of the blood vessels getting clogged up by the sickle cells, causing some intermittent chest pain. Would be pretty unusual. And almost every child that's born is screened for sickle cell, regardless of your ethnicity or race. So most of the time you would have known about that much younger. And cocaine, always a concern, because cocaine and marijuana can cause vasospasm, in which the blood vessels can squeeze together, kind of for no good reason, except for the cocaine and the marijuana. So in that case, it's almost like a ischemic event, where there's decreased blood flow because of the vasospasm. So at least asking about it is useful. Okay, so some really key points about precordial catch. It's very characteristic and it's consistent in how it's presented. It's usually sharp, stabbing, needle-like, boom, and then it goes away. And usually the patient can point to it with just a couple of fingers. So you know that it's right in that same area and it's going to go away after time. So listening to them well, doing a good history and physical. And you don't necessarily have to do blood work or EKG or chest x-ray. If the characteristics are consistent with this condition, then that's kind of good enough. Part of the reason why this kid told me he wanted a stress test was because he would complain every now and again when this happened to his grandmother, and his grandmother, who was in her 60s, would go, oh, my girl, my so-and-so down the street, she had the same thing and she had a heart attack. You better go tell your doctor you need a stress test. So getting information from neighbors and friends can be useful, at least makes you concerned, but you can't, the condition of a 16-year-old versus a 60-year-old, a little bit different in terms of what the etiology would be. All right, so those are the characteristics of it. Sometimes it can be worse when you take a big deep breath, but usually it's gone fairly quickly. So with those characteristics, you can feel much better about it. Okay, are you ready for the next one?
Yes,
All
we
right.
are.
So I put in here a little bit of the etymology of where the words come from. That is going to be so helpful when you are studying medicine. So myalgias, if you didn't know what that word meant, but you know that MYS or MYS is from the Greek talking about muscle, and you know that algos is from the Greek meaning pain, myalgia would give you some idea that we're talking about muscle pain. All right, so this hopefully is going to be kind of a fun one for you. This is a 13-year-old, otherwise healthy young girl who is complaining about more and more like muscle and bone pain. She really describes it more of a muscly ache. There wasn't anything that really made it better or worse. It's a chronic pain. It seems to be there regardless of whether she's been exercising. It doesn't stop her from activities. It doesn't stop her from going to school. She's tried a little Motrin every now and again, but it didn't seem to matter. It's definitely worse in her legs, but excuse me, it could be anywhere. One of the key characteristics is it does not wake her from sleep. So I want you to think about this in the chat. Anybody know why? When a bone pain wakes you up from sleep, what are you really worried about? So think about that while we look in the rest. We specifically asked about joints, and this is not in her joints. It's not in her knees or her hips. She doesn't have any swelling in your joints or pain or stiffness in your joints. That's really key. Another key point. Anybody give me an answer yet in the chat about bone pain and during sleep? No?
Not yet.
Okay. Well, I'm just going to tell you then. If a pain wakes you up from sleep, I always worry, is there a cancer? There should not be a pain that wakes you up from sleep. You might wake up in the morning thinking, I didn't sleep very well. But to wake up with an acute pain in the middle of the night, something's wrong. And that is not an unusual presentation for bone cancer, for example. Okay, so for her, not the case. So good. Nothing that she does seems to make it better, whether you put a hot pack, a heat, a cold pack. It's just this kind of dull ache. She doesn't have any significant past medical history. And like I said, she took an occasional Motrin, ibuprofen. And she just kind of comes in because her complaining about this intermittently now for the last few months, and she's kind of getting tired of it. So I want you to listen carefully to the family history and see if you can help me figure out the diagnosis. She's in the 8th grade. She lives with her mom. She's not really actively involved in sports. She kind of plays around, on the field during recess and stuff. But she definitely hasn't noted that it gets worse when she's running or exercising or anything. Confidentially, she has not been a smoker. She doesn't drink, do drugs. She's never been sexually active. She does okay in school. Not quite sure what she wants to be when she grows up. Her family history: her mother is alive at the age of 38. She has some high blood pressure. She's a little lactose intolerant. She doesn't know much about her father's history or any of the folks. She's an only child, so she doesn't have any siblings. Her mother's family is otherwise pretty healthy. She started having her periods at the age of 12, always an important question for young girls. But on review of systems, she doesn't have any other really major complaints. Cardiac, pulmonary, GI, she sleeps well, no depression, etc. And on exam, except for initially a slightly elevated blood pressure of 136/77, later it was relatively normal. Her BMI is 33, so a little bit high for her age. So anything in the family history that y'all are considering? Did you pick up on any clues?
While we wait on that response, one person did suggest blood clot as the possible reason for sudden waking up at night, but yeah, cancer was the one. And while you wait for other responses to roll in, let's go through maybe one question. So we know this is all about adolescent medicine. What specifically drew you to this patient population?
Oh, thank you. While doing internal medicine, you technically can go down to the age of 16. What drew me to adolescent is that I really enjoyed working with some of the younger folks. When I was initially in practice, I was one of the few women to practice in my hospital system, and so the employees kept coming to me and they kept bringing me their kids, and I really enjoyed this age group. So I spent some additional time and got boarded in adolescent medicine as well. And I think part of what drew me to adolescent is there's so much fun. They're so grandiose. I have met so many potential pro basketball players. Some of them who didn't even play basketball in high school, but everybody wanted to be a basketball player. And I think when you make a difference at this age, you can make a difference for so much longer in their lifespan. So I really enjoyed this group. And to be honest, I don't really like peds that much. The little babies didn't really entice me. But I liked being able to, starting at the age of 12, I can keep them until they're 100. So it's a lot of fun. And there's a lot of different kind of issues. It's more about preventative medicine than anything else.
Absolutely. Well, we do have some answers that rolled in. Hypertension is one, lactose intolerance is another. Another student asked, does the child have gas or diarrhea a lot? If so, I would think she could be lactose intolerant. If not, then maybe hypertension. So we have a toss up between the two.
Good. I like that, y'all. So hypertension is always a concern. Hypertension giving you muscle aches would be a little bit of a stretch because we consider hypertension to be the silent killer. You don't know it's happening until you have a bad outcome from it. But that's always a good concern, especially because she's a little bit overweight and her initial blood pressure was elevated. So thank you. So lactose intolerant, absolutely. She doesn't complain of diarrhea or a lot of gas, but how would the lactose intolerant give you this muscle aches? But you're on the right track, so let's kind of just keep on going. But thank you for that. Did do an x-ray. X-ray was fine. All right, though sometimes with younger folks in pain, you do have to be worried about things like osteogenic sarcoma, slipped skiffy, we call it, which is slipped capitis at the top of the bone of the hip kind of slips, and so they can have some odd type symptoms, but okay. But so it was done. It was okay. The one thing, if you want to say, is there something fractured or not, make them jump on it or hop on it. If you have a broken bone, you cannot hop on it. So that's a great first step. But okay, the x-ray was done. Really probably didn't need to be, but okay. So because of the muscle aches, because of could she have lupus, could she have diabetes, could she have any one of those things, did some baseline labs on her. And bottom line is, these are all normal. Normal doesn't always mean okay. So one of the things I want to draw your attention to is alkaline phosphatase. So all of these are normal, and our alk phos is normal. The issue, though, is in an adolescent, in a kid that's growing quickly, their alk phos didn't happen to me. I'm only 5 feet tall, but I know it happened to other folks. So what you expect in an adolescent is actually to have their alk phos elevated. And in hers, it was not. So something is making it so that her alk phos is not as high as it should be. Are you ready? Did anybody give us any answers, Michael, about why the lactose intolerance would be an issue?
No.
Okay. Well, we're going to have your answer for you. And I want y'all to be thinking about why. Okay, so whenever we do a differential, we always think of every different possible organ system. So we went through a lot of things. Here's your answer. So those of you who picked lactose intolerance, you are right. But you are right because if somebody is lactose intolerant, then they're not drinking milk. And so I asked y'all, how many glasses of or servings of dairy did you have today? The recommendation for just the calcium is 3 servings of dairy a day. Yes, 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 you can get your calcium in other ways. It's like spinach, but it takes you 4 cups of spinach to equal the amount of calcium in 1 glass of milk. So, okay, you can see I like the dairy. But in terms of vitamin D, the best places to get it is from the sunshine, okay? But think about this, the darker your complexion is, the more time you need in the sun to actually absorb the rays to help your vitamin D in your skin turn into active vitamin D. So if you are dark complected, you are going to have a harder time getting up that vitamin D. Then if you avoid dairy, you're having an even harder time. Then the only other spot where vitamin D is occurring naturally, and I take that back, vitamin D does not occur in milk naturally, it's added. It's added to all dairy products in the US. So it's definitely in there, but it's not there naturally. Okay. It is naturally in things like fatty fish, salmon, mackerel, herring. There is no fruit or vegetable that has vitamin D in it. Some cereals are sprayed with vitamins, and that include vitamin D, but naturally it's only sunshine and fatty fish like salmon, mackerel, or herring. It is in all dairy products in the United States. So whether it's yogurt or cheese, whatever, it's all in there. So for this girl, her vitamin D level was pretty much non-existent. The normal is anywhere from 30 to about 100. So we could even find it in her. It was less than 12. This gives you kind of a schematic of like how vitamin D kind of gets into your system, and it's processed first through the skin, then into the liver, then into the kidney. So at any one of those places, if you have difficulties with that organ, you could have some abnormalities in your vitamin D level. The other place where you see it a fair amount is in people who have GI symptoms. So inflammatory bowel disease, where they're not absorbing things well. Celiac disease is another really good one. Cystic fibrosis. Anything that impairs your ability to digest foods can impair your ability to absorb vitamin D, hence leading to lower levels. So probably a lot of folks measure it on a regular basis. I don't think we need to do that, but definitely keep it in mind. And now I asked you how many of you had your 3 servings of dairy a day. Perhaps you can answer me that. And if you haven't, think about how to put it in. Michael?
We haven't had any answers on that. But while we do wait for maybe some of y'all to put them in, we had one question about this case here. So one student asked, what would make you think a lack of vitamin D without first going ahead and asking if the child goes outside a lot or what kinds of foods they normally eat?
Absolutely. A 24-hour diet history is always included in every history, and it should be whether they're just lunch, dinner, snacks, etc. It gives you so much information. And in her case, they did a little fast food. She was eligible to get lunch at school, but she kind of didn't like what they had. And in her case, she would have sometimes she'd eat a pizza, drink some soda at home, and that was really about glasses of milk to drink in the morning because she knew how much it affected her. So you're absolutely right. The 24-hour diet history is incredibly important and probably one of the things that I include with every visit. But some of the reasons why I considered vitamin D in her was also the character of the discomfort, the character of the pain. It wasn't in the joints. It wasn't associated with stiffness. That would be more rheumatologic, like lupus, rheumatoid arthritis. It wasn't associated with exercise. Exercise-induced pain usually tells me there's some kind of an ischemia going on. So, for example, I had a 15-year-old with coarctation of the aorta, and that's an abnormality in which the aorta is not formed properly. And so when he started running heavily, he would get nasty cramps in his legs. And he just thought he was out of shape when actually his aorta was not formed properly. He wasn't getting sufficient blood supply to his lower extremities. So much comes by the questions that you ask and the description. And so you asked about her being out in the sun. Absolutely. How often do you go outside? Tell me about your day. Not being involved with sports, you can kind of assume that there's not going to be a lot of outside activity. Where do you live? I mean, are you able to go outside and run and play? For a lot of kids, that's not true. For some, especially if you're coming home and you're a latchkey kid coming home living by yourself, you're going to have to go in the house and stay there until your mom comes home, and then at that time it's late. So good question. All right, shall we move on?
Go ahead. We did have one question, though. We didn't get any responses on how many servings of dairy that y'all have, but we did get another question asking, would milk substitutes be okay to get enough vitamin D?
Oh, I'm so glad you asked that. So in theory, most of the milk supplements, well, none of the milk supplements have vitamin D naturally. The only ones that have calcium naturally is almond milk, because almonds do have a small amount of calcium. All the calcium and vitamin D is added as a powder. So just like in milk, where vitamin D is added to milk, adequate amounts, but you have to remember to really shake the bottle or shake the carton. Because it's added as a powder, it sticks to the sides of the wall of the container. So that's why it says on the top, it says shake well, and most of you guys probably are like, whatever. That's the reason why they say that. So if you shake it really well, it helps to get that powder more dispersed into the liquid, so that when you do drink it, you do get the calcium and vitamin D. Good questions, thank you.
We did actually get
sunshine. Oh yeah, go ahead.
Yeah, we just did get one response on dairy intake, 2.5 servings a day, and they're a 20-year-old male.
Hey, well, I appreciate the 2.5. Make it 3, and then you'll get enough calcium. But get out into the sunshine when you can. Of course, always with because burn increases your risk for skin cancer later on. But one of the cases that we had in peds was a newborn who developed rickets, which is pretty severe vitamin D deficiency associated bone abnormalities. And in that case, it was kind of sad. Nice little kid, great family. Mother was a dermatologist, really wanted to do everything right for her son. So she only breastfed him, which was great, but breast milk also, if you're solely breastfeeding, you have to supplement your child's diet with vitamin D supplements. So she was trying to do all the right things. She only breastfed. She wasn't doing any supplements. She was so concerned about skin cancer, and she's a dermatologist, so she slathered that kid with sunscreen every time he went out, and he developed rickets. So there can be have to give them extra to help it get it into the system. A multiple vitamin has about 400 units of vitamin D. A daily supplement is 1,000. You'll notice that any vitamin D supplement comes as kind of a little gelatin capsule. You have to kind of poke that capsule with a pin before you take it in, partly because some people don't digest the gelatin, so it may not actually think you're taking a supplement, and it's just going right through you. So my bias is I'd rather get it in through the food that I eat and sunshine, and not deal with the supplements. Okay, going on.
Yep.
And I'm happy to talk anything about diet and nutrition, because I think that's the building blocks of how we treat our bodies. So this is a 16-year-old with vaginal bleeding. She's otherwise healthy. She had her menarche at the age of 13, so she first started periods at 13. They've been normal, quote, ever since. This time her menses started about a week ago, and she said it was normal at first, meaning for her 3 to 4 pads a day, but then it got to being a maxi pad change every hour for the last 2 days. And any of the women out there know this is too much bleeding. This is obnoxious. This you're worried about bleeding through your clothes when you're sitting down in class. It seemed to kind of slow down a little bit, and then now it's increased again, and she's to the point where like every 45 minutes she's got to change her pad because her pad is soaked. She's also complaining about feeling weak and dizzy and tired. Interesting, her past medical history, she was supposed to have her tonsils taken out about 10 years prior to this, and they did what they called a bleeding study, where they don't do it so much anymore, but we used to prick your finger with a pin, and then take this little sheet of paper and put it next to your finger, the bleeding area, and see how long it would take for the bleeding to stop. That's called a bleeding time. So she had something done right before her tonsillectomy. Her bleeding time was a little bit prolonged. They didn't really know why, but they did not pursue the surgery, so she did not have her tonsils out, and she hasn't had any surgery then. A couple of interesting things to be thinking about when you're asking, what is normal menses? So every woman is a little bit different in terms of their blood flow. So you want to know what's normal for her and how has that changed. So she's always had menses, or periods have always been relatively heavy, and that she's using 3, 4, 5 pads per day, and then it lasts about 5 to 7 days. It seems more than what some of her friends do, but it's always been that way, so she wasn't too concerned. This time, though, she's bleeding a lot more. Her social history, she's a high school soccer player, so physically active, no tobacco, drugs, alcohol. She's never been sexually active. But even when somebody tells you that, if you're a girl and you're menstruating, you still have to do a negative pregnancy test. So that's just always going to be on the list. Her review systems is pretty non-contributory, maybe a little mild nausea, but other than that, not too bad. She gets, you see her right now, and her blood pressure is 92/60, so a little on the low side. When she's lying down, she also has a heart rate of 95 when she's lying down. So we call this the blood pressure drops to 70/45, and her heart rate goes up to 120. So she's definitely orthostatic, and that should make you worry that she's had some significant blood loss, because a normal person who's not dehydrated should not have orthostatic changes like that. She's relatively afebrile. On exam, you notice that she's pale. She doesn't have any easy bruising on her skin. And when you do a pelvic exam, you notice blood in the vault, but you don't see any masses. All right. So she did get a transvaginal ultrasound, probably because you can have things like fibroids that might cause excessive bleeding. Sometimes we'll have folks that have a vaginal septum. So in the vagina, there's actually a little wall down the middle, and if somebody is sexually active when they've had that vaginal septum, they can actually rip it, and that can cause bleeding. And you don't see anything except that she's got a fair amount of fluid still in her pelvis. A bit of a cyst. That's probably more related to her recent menses. We absolutely have to do a beta HCG, negative. Prolactin, that's done because hyperprolactinemia can cause irregular menses. And so knowing that she doesn't have a prolactinoma and normal prolactin level says that the problem is not coming from her brain, it's coming from something else. So we did some bleeding tests. So a PT, these are both clotting kind of things. How long does it take for your blood to stop? So the PT is really influenced by certain medications, can be influenced by the liver, and the PTT is a prolonged thromboblastin time, and I'll show you a little bit more about that. Look at her blood count. Normally, a woman should have a blood or a hematocrit of between 35 and 45. Hers is 20. So you know this has dropped a fair amount. No wonder she's feeling so poorly. Her platelet counts are okay, and her MCV, which is the mean corpuscular volume, which is the size of the red blood cells, is still relatively normal, which again makes you go, oh my goodness, that's a lot of blood loss, because her red blood cells are all still the same size that they should be, but her blood count went down so significantly, and she's orthostatic. So that says something's major going on here. I have to resuscitate her in terms of giving her fluids, perhaps giving her some blood, but then also figuring out what's the cause of this bleeding. Any thoughts, Michael, in the chat?
We just have a question so far. How's the patient's diet?
She is a very good eater. In fact, she's not vegan or vegetarian. She loves red meat. With all of that running around that she's doing, she is very conscientious and gets her, not exactly her 11 servings of fruits and vegetables a day, but somewhere between 5 to 7. And her parents say that she's never been a picky eater. She downs everything that she can get. But I'm so glad you asked that question, because especially if you're young and female, and actually I've had this in others as well. I worked with eating disorder patients for about 12 years. So thank you for asking about diet, because that is absolutely key, making sure that she's getting everything that she needs. All right. Any other thoughts?
Not so far, but we can move on.
Okay.
Yeah.
All right. So I just wanted to show you the couple of pathways, and this is sort of how these are the kinds of things that you learn in your first and second year of medical school, and you think, why am I learning all this stuff? But oh my gosh, then you use it as you go on. So the test of the clotting pathways, there's 2 basic clotting pathways. There's a lot of intricacies in them, and you can have abnormalities at any place along the road. So the PT is the one section on the one side just says it's a little bit more influenced by liver, and the PTT is on the other side, and it's more of a intrinsic pathway. So keep those in the back of your mind, and I'm just going to move on because this is von Willebrand's. And I think von Willebrand's is so interesting because it's a sneaky bleeding disorder. You don't always know that it's there until you go to take your tonsils out and all of a sudden you're having bleeding diathesis and they can't stop the bleeding. A lot of times, this came about actually because von Willebrand, he was German, got very interested in blood disorders when he treated a 5-year-old patient who had active bleeding that was difficult to stop. And so he looked into her family and found that of the 66 family members, 23 had problems with bleeding abnormalities. And so because of that, then they started to look into, there must be some other factor here that we're missing. He helped to figure out the factor that was deficient in this one family that led to excessive bleeding, hence the name von Willebrand. I think you'll find that most named diseases or procedures in medicine are of old white guys because they were the ones that practiced for so long. But we're changing that now. So the screening questions for von Willebrand's is not only have you ever had any bleeding abnormalities, so in this patient, it was because the bleeding time was abnormal when she went to go get that tonsillectomy. That was a little bit of a clue. The fact that she had relatively heavy periods or prolonged bleeding with them more than her friends. But also, if you go to take your wisdom teeth out and you bleed like stink, something's wrong. Or especially asking about friends and family. If there's ever been a family member who had a hemorrhage after giving birth, or needed a blood transfusion after a minor surgery, all of those kinds of things should pique your interest about what was going on with them and could that potentially be me. So any of these questions are always good ones to ask in terms of screening. And I love to kind of be thinking about von Willebrand's because it just kind of sneaks up on you, and it's not always an easy one to find. So in her case, yes, she had von Willebrand's, and so the treatment is, one, decrease any reason for bleeding. So why have heavy periods? Why have a period at all if we can stop those? So using combined oral contraceptives is a really helpful. Estrogen also really helps. If you don't want to do contraceptives or you're a guy, then you can use vasopressin. Desmopressin helps to get more of the von Willebrand's factor out into the system. So there are ways of actually treating and managing that. Okay, do we have time, Michael, for another one?
Absolutely. I just did
Okay.
a quick, we had a quick few questions just about the last case, and we can definitely move on to this quick. But we did have some guesses at endometriosis. That was a popular guess that just rolled in just as you were going through the differential. Why would you say that would be ruled out? Like, what about endometriosis would not fit in this case?
So endometriosis is more likely to be associated with pain than with excessive bleeding. So endometriosis is little bits of the uterine lining that can be anywhere else throughout the body. And because of that, they're not necessarily under the same hormonal control. So I've actually seen, and we found endometriosis in the lining of the gut. We found endometrial tissue in the lining of the bronchial tree. I had one woman with recurrent ascites, that was bloody ascites. Ascites is fluid in the belly, because she would have an endometrial lesion that would bleed intermittently that was in her abdomen, not in her uterus. So endometriosis is little bits of uterine tissue that are not where it's supposed to be. Because of that, they can bleed. Because of that, they can make a little cyst. Because of that, they can also cause scarring. But it's more associated with pain than with excessive bleeding. But you're on kind of the right track. If you think about it, fibroids, which is a different category. Fibroid is almost like if there's a little rock in your uterus. And so when the uterus is supposed to contract to decrease the bleeding, I mean, that's what that cramping is. It's like that contraction of your uterus, and that helps to squish the blood vessels that are in the uterine wall so that they stop bleeding. If you have a fibroid, it's like having a rock in your sponge. You try to compress it to squeeze all the water out of your sponge, and you can't because there's a rock in the middle. Fibroids can be associated with increased bleeding, which is part of the reason for looking for them. They are less likely to occur in younger people than in older folks. So it would be less likely in a 16-year-old. But I love your thought about endometriosis. I think we do not pay enough attention to that. And it's also sometimes a very hard diagnosis to make because the endometrial lesions can be so small that you don't notice them on CAT scans and ultrasounds. So great, thanks for bringing that up. Okay, we only have a few more minutes, so I'll try to go through this one a little bit quickly. This is a 13-year-old with back pain. He's a hockey player. He started having back pain at the end of the season in March or so, and he complained about it. And this kid doesn't complain much, but he would be sitting at the dinner table. Okay, full transport. This is my son. Okay, so any of y'all, when you're becoming a physician, you will make mistakes. I'm just going to tell you right now. So this is my son. He's sitting at the dinner table with a heating pad, taking ibuprofen, complaining about his back, and I'm like, you know, kids, suck it up. You know, you're a hockey player, you're going to get hit, suck it up. But this summer he did okay. It wasn't so bad. But then he starts back into hockey season. He's trying, really hard, and this pain comes back. I'm like, oh, shoot, So he's otherwise fairly healthy. He doesn't have any major complaints. And this kid eats well because he's my son. And so, anyways, so what we did is we do this special test called the one-legged hyperextension test, or you could call it the flamingo test. This is a very specific test for a pars defect fracture, otherwise named spondylosis. So you do just like this, and you see where this person's thumb is. If you can recreate the pain by having them lean backward into you, you probably have a pars defect fracture. And it doesn't have to happen like yesterday and you have the pain today. One of my cases was a girl who had a fracture 3 years ago, or had an injury 3 years ago. And because it never healed properly, she continued to have the pain. And another kid was diagnosed with a bad bone bruise, but in actuality, it was a pars defect fracture. This occurs more commonly in young kids, adolescents, and the idea is that they're growing, but the bones are not mineralizing as fast. So, for example, probably the typical case is a kid in high school playing football. As they should, and so the ligaments are actually kind of pulling apart that bone, which is then causing that fracture of the bone. This we call the Scotty dog, and you kind of see where those black arrows are, and maybe you can make kind of the outline of this Scotty dog. So when you start medical school and somebody goes, oh, the Scotty dog sign, you're going to go, oh, pars defect fracture. I know that one. Absolutely. And if you can't see it on the plain films, then getting a bone scan or a CT scan is helpful. It usually goes away by itself. Well, it usually can heal on its own. It doesn't need surgery. Sometimes you'll use a brace. In my son's case, he couldn't play hockey or skate or do anything for 3 weeks, which was killing him. And then he had to use this brace for the rest of the season whenever he skated. But it made him skate more up than anybody else. So he still has kind of a funky way of skating, but he turned out to be fine. Most people get better. It usually goes away. There's no great way to prevent it, but you just have to be conscientious about the fact that younger kids who present with back pain, it's usually structural, not functional. Older people with back pain, it's more functional. It means that it's the muscles and the ligaments and just old age and things not moving properly. For a younger person with back pain, you should really think something else is going on here, and I need to get more involved and invested in looking at what that is. Okay, so I think we're just about out of time. Any thoughts, any questions, anything else we can kind of bring up for you?
Well, we did have one question going back to to the second to last case, and then maybe we can just cover some general questions. Y'all feel free to shoot any questions our way through the chat. Do you mind if we take 5-10 minutes for the Q&A?
Sure.
Okay, cool. So going back to one of the earlier cases, a student asks, can not removing your tonsils affect vaginal bleeding?
No. The the comment about the tonsils was only the fact that because of her abnormal bleeding test, the surgical procedure was canceled. So it was the fact that she had an abnormal bleeding test that led the surgeons to go, I'm not going to take out your tonsils. So the abnormal bleeding was probably the fact that she had von Willebrands, and that was her first sign of it, but nobody followed up on it, or they canceled the surgery and things were done. So it wasn't that taking out the tonsils would have anything to do with her vaginal bleeding. If they went ahead and took her tonsils out and she had a bleeding diathesis afterward, where you can't stop the bleeding and then she needs a transfusion, that would have led most likely for them to make the diagnosis earlier. But I'm glad you asked that question, because tonsils, vagina. Yeah.
Exactly. Another question just popped up about the earlier case on your son. Would going to a chiropractor possibly make back pain worse or better if someone is to have a spinal fracture? So generally, would you recommend worse? Okay.
Worse. Especially in a younger person, have it evaluated properly first. Okay. Everybody's spine is a little bit crooked. Everybody's spine isn't perfect. But in a younger person with back pain, they should definitely be seen by a physician, potentially by a sports medicine physician if it's as a result of an injury. And if have that evaluated first before you go on. My bias is I prefer using physical therapists. They are fabulous. They know so much about how the muscles and everything interact, so that if I've done the workup that is needed and the patient isn't getting better, or I can document that this is more of a spinal, a nerve problem, I would prefer using my physical therapist first, because they also teach them the exercises that you can do at home to help strengthen. It's not that chiropractors are bad. We all need everybody, but there are situations where the diagnosis was incorrect, and they're just not able to do as many of the maneuvers that help to make that diagnosis.
I think it's cutting out a bit.
But generally not for younger folks.
Okay. Just a general question about your career. So just like we introduced you in the beginning, you later have got into leadership roles of your own. I believe you were the past president for just last year. Is that right? For AMWA?
Correct. Right.
So how did you develop your career into paving that path for yourself towards leadership?
Well, and I am on the admissions committee for the Medical College of Georgia, and have been on admission committees, in a lot of different places for residency, for medical students, etc. One of the things we always look for is leadership. And partly that's because as a physician, you're leading a team, whether you're in your own office or whether you're in the operating room. You are leading a team, and you're also educating. You're educating your patients, their families, etc. And so I think that medicine in general kind of self-selects for leaders, and we kind of encourage it. And so it's not uncommon for physicians to be looking for other ways of increasing the opportunities for leadership. For myself, I found it very useful to have people that I can network with, and it made a huge difference. And I became a full professor in 2017. And at the time that I became a full professor of medicine, there were approximately 35,000 faculty members at medical schools in the country. Of those 35,000, only 20 were full professors who were women of Mexican American heritage, of which I am. My mother's Mexican. Um, and I made it 21. And that was important to me. So being involved with AMWA got me to have networking capabilities for physicians across the country who could write me letters of support. But it also gave me kind of a team, so that if I had questions or I wasn't sure about something, I could speak about that with a colleague and not worry about any implications to my work or my job. And so having opportunities to be involved with organizations, I found has been incredibly important for me and for my career.
That is some wonderful insight. And well, like you said, medicine does kind of self-select for leaders. You never
It's one of our
necessarily.
check boxes, folks. It's one of our check.
Yeah,
It's one of our check boxes. We kind of look for, what have you been involved with? How do you demonstrate that? And leadership doesn't always mean that you have to be the president of your group. It's finding ways of creating change and making opportunities. For example, one of our applicants, their letter of recommendation was from a professor who commented on the fact that this student was a good student and everything, but also commented on the fact that the other students came to her for their opinions, and she started a study group with them, and all the students' grades improved, all those that were involved with her study group, because she made the effort and she put things together. And even though she might not have been the smartest one in the class, she had this ability to pull people together to make change, and have action. And that's a leader.
definitely a great example to illustrate it. We'll go through maybe 3 more questions if you have time.
Sure.
These first 2 are about cases. So when a patient ever comes to you, do they usually come to you via appointment, or do some patients come from the ED and you happen to be assigned to adolescents?
I'm sorry, Michael, I froze. So I'll and maybe go inside and see if you want to say it again.
No worries. So one student was asking, how do patients typically get to see you? Is it usually via an appointment, or do some patients go through the ED?
Oh, for me, it's usually appointments. They have to come to the office or telemedicine these days. We've worked in free clinics and things like that. So I'm not an emergency room physician. And although I thought about that once, but I'd say the majority of the time the patients come to the office. Now, sometimes they might have been referred from the emergency room. But oftentimes too, we've seen patients because we've done their sports physical exams, and then that gets them into the office. And so then that's how we've become their primary care physician.
You mentioned VWD earlier. Is that part of newborn screening?
Von Willebrand's, no, it's not part of newborn screening. Newborn screening tests are usually done to diagnose early those things that have to be treated initially. That can make a big difference. So things like sickle cell, other things like oh gosh, I'm losing it. It's an inherited metabolic disorder, PKU. Okay, that's another one. Every state has a different list of what types of testing that has to be done for newborn screening. And that testing is usually paid for through the Department of Health, but not always. So a lot of times it's through your insurance. So every state will have a different list of things. Most of the time they're relatively rare conditions, but they're rare conditions in which if that genetic mutation is not treated appropriately, it could have severe impacts on that child growing up. So if it's a inability to digest fatty chain acids, then you can actually make sure to not give that kid fatty chain acids so that they can grow up to be a relatively normal person. So
You mentioned earlier that you were also on the admissions committee for UGA. So I know that quite a few people are going through the application cycle right now. I think a couple of people also have their interviews sent out too. It would be helpful to hear anything in terms of tips that you think are not voiced enough, tips that might be overlooked in interviews, or possibly if you have any examples, just like you did for one of your earlier applicants, of any interviews that really wowed you for a certain factor that a interviewee had.
So many schools are now doing MS Ah, MSIs.
MMI?
MMIs. Yes, thank you.
Yeah.
And they're these quick 5 minute 5 minute things. So let me tell you, and some are doing, the full length ones. Most everybody's doing virtual still, and I'd say virtual is perfect and fine. Okay, however, think about what's behind you. Okay, I mean, right now, I'm talking to you all, so I'm not worried about it. I would not do this if I was interviewing for medical school. I would be in a position where the room is quiet, it's soundproof. Many colleges will have virtual interview rooms that you can sign up for. Do it. Because you don't want the fire truck to come by while you're trying to talk to somebody virtually. You don't want the power to go out. Those things have happened. You also want to say, look and see what's behind you. I had one interviewer comment on a student and say, his hair wasn't looking so good. He had all these papers on some bulletin board behind him, and it was just too distracting. Okay, here's the other thing is, oh, for God's sake, do not interview in your freaking bedroom, all right? Oh my God. The last thing I want to see when I'm talking to you is your bed behind you. It's just annoying, even more so when it's not like, made. We had one person, I commented on the stuffed animals and he pulled one up. Oh yes, and this is Harry. And I'm like, okay, yeah, no. Another guy is interviewing in his bedroom and his mom comes in to get his laundry. Hi, honey, I'm just gonna do your shorts today. Okay, no. Have your room be soundproof. Have the information, whatever's behind you, to be appropriate. Don't have something that is just like a statue and a piece of it is just sticking out over your head. Yeah, not good, not good. Put your interview outfit on and have somebody do a virtual interview with you so that they can comment on the fact that, your bra strap keeps showing, or that tie always looks crooked, or, if you're not comfortable in what you're wearing, it's going to show.
Absolutely. Presentation, very key, especially as we're doing it over Zoom here. I think that will wrap up today's session. First of all, thank you so much, Dr. Rohr, for getting this all together. This was a wonderful presentation. I think it might have been the first, if not the second time, that we've had adolescent medicine.
Oh, good.
So it's a fresh specialty, and I learned a lot. These cases, a lot of learning on my side, and I'm sure a lot of students can say the same. I do have some last reminders for y'all before we do end. So we do have a quiz that's now posted in the chat. We do also have it in our video description and also on the website. It'll be due on Wednesday, August 2nd at 11:59 p.m. Central Standard Time. Feel free to reach out if you have any questions. If you pass with at least 6 or 10 of those questions correct, then you'll receive a certificate and that will be sent to your inbox, your email inbox. This quiz will be due within 1 week, but if y'all want to view this session or any of our others, you're always free to. These sessions are up indefinitely. And for our next shadowing session, we're going to be joined by Dr. Soburn Kassar. She's the medical director at Encompass Health Rehabilitation Hospital of Greenville in South Carolina. We'll see her on Monday, July 31st at our usual time of 7 p.m. Central. And let's hear some thank yous in the chat for Dr. Rohr. She took some time today to join us. We had some wonderful questions from y'all. I really do appreciate all the questions and a lot of engagement. This is just a very fun session all in all. Thank you so much.
Good. Thank you. And include this when you talk about your clinical time. You can include your virtual shadowing. So please do put those number of hours in, because it helps us on the admissions committee to know that you have taken a special interest and that you're going above and beyond. So even though it's not clinical shadowing in a hospital or an office, you're learning something about medicine. So include these hours in that.
Definitely. All right. Well,
All right.
we'll see you.